Okay, so the other set of issues that can be a challenge when producing a robust estimate of cost effectiveness were all to do with how do we value the time spent in different health states. And just to remind you, this is important because it's going to determine your QALYs. What this valuing time spent in different health states is really referring to is the QA part, the quality adjusted part of QALYs, or quality adjusted life years. To remind you, this was Wednesday morning, there's a limited range of preference-based generic measures. Far and away the brand leader is EQ5D, but there are other ones, SF6D, HUE, etc. There's quite a few issues as to how we elicit preferences. Now, I didn't go into a lot of detail on this because it's the sort of thing you could have 2 whole lectures just on eliciting preferences. But you'll recall what I did talk about was the time trade-off method, or TTO. This idea that you ask individuals to do a hypothetical comparison between time spent in an ill health state, which you've described to them, and a shorter period of time in full health. And the basic idea is that individuals will be willing to give up some part of their time in ill health in order to be in full health. And so that's the time trade-off. And depending how badly they view or how severe they view the ill health state, the more time they would be willing to give up. Now, time trade-off is just one method. It is currently probably the most widely used method, but it is just one method, and it has a few problems, but I won't go into them in detail. So that was one issue. There's different ways of eliciting these preferences. Second issue is, having elicited preferences, we actually don't just want scores for a subset of health states. We want a full set of scores, a tariff or value set. We want a score for every health state. Now, that's quite difficult because if you think of EQ5D5L, there are 3,125 different health states. And if you've done a survey that's valued 89 of them, you've got to get from the 89 health states to the 3,125 health states. And so there's issues there. Essentially, you model it and then make a prediction, but that's got its own challenges. There are at least 4 options when you want health state valuations for economic evaluations. One is, and this often is the preferred option, you want patient-reported data, but valued using public preferences. So patient-reported, that's the patient saying how they are. It's the patient completing, say, an EQ5D questionnaire. But the public preferences, the idea is the people who have scored the health states, the people you've done the time trade-off with, are not the patients, but the public. Now, this is something it's worth us spending a little bit of time on, because it's not obvious to most people why we use the public. So one argument that's made is that patients know the health state. They experience the health state, they've got the condition. They don't have to imagine it. They know what it's like to be in that health state. The general public don't know that condition. They don't necessarily have any experience of that specific health state. So how can they imagine themselves in it? How can they give you a good, realistic valuation of how relatively bad or good it is to be in that health state? Do you agree? Should we get public to value it, or do you think we should get patients to value health states? For the reason they know it. It's not hypothetical. Mm-hmm. You agree? Yeah? But in practice, we almost always use the public. If you remember, I gave you a large table. This was EQ5D3L, had about 24, 26 countries in it who had valued the EQ5D3L using time trade-off. All of these were the public. It's true the Swedish study involved people valuing their own health state. And so for them it wasn't hypothetical. But for everybody else, individuals were asked to imagine being in a particular health state. Well, there's a number of reasons why that's the dominant approach. Now, there's a certain amount of discussion going on as to whether it should be, but one argument is this. In a publicly funded healthcare system, such as, in effect, Japan is publicly funded, predominantly, NHS in England is overwhelmingly publicly funded. In a publicly funded health system, it's the public we should ask because they are paying for it. That's one argument, a sort of political argument. Another argument is that, yes, patients have experienced the health state, so they don't have to imagine it, they've experienced it. But what seems to happen is patients learn to cope with being in a particular health state. And so over time, they start thinking, it's not so bad. Particularly a chronic condition where they may have little chance of getting out of it, or relatively low prospect of avoiding the health state. It's maybe a good thing that patients learn to cope. But the problem there is that we're then getting a different view of how bad or good it is to be in that health state. We're getting one that's been sort of adjusted by experience. And so if we're then thinking about what steps should we take, for example, prevention to avoid people getting into a particular health state, do we really want to know what the patient thinks of it eventually once they've coped? Or is it not more reasonable to be thinking about what the public regard, how bad or how important they feel it is to avoid that health state? The other argument that's made is, yes, the patient is the expert on that condition, but they're only in some of the health states you're trying to value. And you're wanting a valuation for all health states so that you can use your measure again and again, comparing different areas of healthcare. And so that argument would concede that patients are the expert on that condition, but would just emphasize that patients only have an experience of a subset of the health states. And the other sort of argument is, if we take EQ5D or some measure like that, the general dimensions are things we all know about to some extent, either through direct experience or through indirect experience, family members or something like that. And so there's an argument that, we know what a restriction on mobility is. We know what pain is. And so is that not enough? Can individuals, the public, us, you, me, can we not reasonably imagine what a particular combination of these dimensions would be like. Now, there isn't a right answer to this. As I say, the dominant view just now is to use the public valuations. One exception to this was the AQUAL, the Australian measure that I briefly introduced. They've quite explicitly valued it half, or roughly half, I think, with public values and roughly half with patient values. So there's still some work going on out there that would use the patients. Okay, there's that issue. But anyway, we've got various potential sources of values, and so there's an issue about which ones we should use. Definitely there's going to be an area there's going to be more and more research going on. Already it's heavily researched, but I'm sure there's going to be more and more happening in the next few years.